Good morning. Good morning, good morning, good morning, and welcome to everyone. My name is Laverne Price, and I'm with Sister Love Ministries. Sister Love is a Christian fellowship ministry that was born out of Christ's Best Ministries, of which Elder Carmen Riley Bazile is both the CEO and founder. This ministry gathers once a year for a Christian fellowship experience focused on mind, body, and soul. Our health component, of which myself, Laverne Price, and Stephanie Marshall are overseers, we're excited and we thank you for being here this morning for our first post-COVID experience entitled The Great Gathering here in Lake Guntersville, Alabama. And this is a gathering of Christian women from all across the United States. So we're excited for each and every one of you that have taken the time out this morning to join in this webinar. We would like to invite you to follow us on Facebook at the Sister Love page. When it pops up, you're going to see a red heart. That way you know that you've got the right Sister Love. Or you can also follow us on our website at www.sisterlove.com for more information about Sister Love and how you can join in. Again, we say welcome, and we thank Black Health Matters and Eisai Pharmaceuticals for joining us for this year's experience as we focus on women's health. Thank you.
And thank you so much, Laverne, and thank you, Stephanie. We go way back, right, Steph? We are delighted to be here. Good morning to everyone. On behalf of Eisai Pharmaceuticals and Black Health Matters, I am happy to extend this greetings to those here in the room with us from Sister Love of God and those also viewing online. We are here in beautiful Lake Guntersville, Alabama. And we know that there are many attending from across the country, so we're delighted to have you. My name is Leslie Garcia Fontenot, and I am the VP Managing Director for Black Health Matters. Black Health Matters is the nation's leading health, wellness, and chronic disease education and multimedia platform dedicated to improving health outcomes in communities across the U.S. If you'd like to learn more about Black Health Matters, you can visit us at blackhealthmatters.com or find us on Facebook, Instagram, Twitter, and LinkedIn. Today, ladies, you will be joined by two of our guests here, and you will get your questions answered. These guests are talking about a topic that's quite frankly not often discussed, and that's gynecologic care. Gynecologic health is an important conversation to have at any age, but it's not often discussed, as I mentioned, especially in the Black community. So today you will hear from our patient ambassador, Ms. Jerlene Rudeau, and Dr. Ebony Hoskins. I'm going to tell you a little bit about who they are, and then we'll get started with their program. So first off, Jerlene Rudeau is Director of New Impression Social Services Agency, holds a master's in social work degree from the University of Southern California. Upon retiring from Los Angeles County Department of Children and Family Services in 2008 as a supervising children's social worker, she founded New Impression, a 501c3 nonprofit agency with two other social workers. New Impression advocates for the elimination of stigma associated with mental health, provides cancer supportive services, and aims to eliminate healthcare disparities. In 2017, Jerlene was diagnosed with endometrial cancer. She is now in her 5th year of survivorship. In March 2019, she was selected by ECANA, which is the Endometrial Cancer Action Network for African Americans, founded by Dr. Kemi Dahl, to join their organization as a community empowerment partner. She was trained at the first ECANA conference in Hawaii, and now is a certified community empowerment partner. In this role, Jerlene is educating and giving her personal testimony to the African American community about facts associated with endometrial and uterine cancer. Next up, we have Dr. Ebony Hoskins. Dr. Hoskins is a board-certified gynecologic oncologist at MedStar Washington Hospital Center. Dr. Hoskins sees women for gynecological malignancies, which include the treatment of endometrial, ovarian, vulva, and cervical cancers, treating women with complex gynecological surgical issues and minimally invasive surgical options for morbidly obese women. Dr. Hoskins received her medical degree from Wayne State University School of Medicine in her home state of Michigan. She then gained excellent clinical skills during her obstetrics and gynecology residency at St. Joseph Mercy Hospital in Ann Arbor, where her training prepared her for a clinical fellowship in gynecologic oncology at McGee Women's Hospital in Pittsburgh, Pennsylvania. She is a member of the Society of Gynecologic Oncology, the American Society of Clinical Oncology, and the American College of Obstetrics and Gynecology. Dr. Hoskins has been named a Washingtonian top doctor in 2016, 17, and 2018, and has published various works, including articles in peer-reviewed journals and abstracts. So please welcome our two speakers. First, we'll have Charlene Nadeau speak. And one thing I'd like to do is remind everyone to visit spotherforec.com, and those attending here in person and online, we have a survey for you to complete after this session so that we can bring other programs to you like this. Thank you. Thank you, Jarlene.
Well, thank you so much for that excellent introduction. I am excited to be here today. Sister Love, this is my first time interacting with your group, but I'm definitely going to get involved with all that you do. This is exciting. And also Black Health Matters. It's always an honor to be invited and come before you. As Leslie indicated, in 2017, I was diagnosed with endometrial cancer. Prior to that, I had never heard of endometrial cancer. Of course, I Googled it. Well, now you guys don't have to Google. We're everywhere now. But back then when I was diagnosed, it was like endometrial cancer. What is this? One of the questions that come up over and over again, what is it? Well, what I did learn and what I've learned, it is one of the uterine cancers. We hear about cervical, we hear about ovarian, but why is it we don't hear about endometrial? And this is why this conference today, this educational time we're spending together, it is so important, because what I always say to each one of you guys, now you guys are going to be ambassadors, because you're going to be able to talk about endometrial. When other people are talking about cancers, you're going to talk about this cancer that impacts. When this brochure was printed, 1 out of 39 Black women are going to be diagnosed with endometrial cancer. That's, if you're in church, you count down 139, that's a lot. So consequently, it is a cancer that we should be talking about. One of my favorite things that I want to say to you guys, one takeaway if you don't remember anything else, don't wait, don't hesitate, go right away. I came up with that for myself. Had I not went right away when I was first experienced symptoms, I wouldn't be here talking to you guys today. One of the symptoms, good question, what is a symptom, Jolene? One of the symptoms is any bleeding, especially postmenopausal. I was diagnosed at postmenopausal, meaning already been through menopause. Once you go through menopause, you should not see any more blood. You will be amazed at how many women that I talked to over these 5 years that told me they just put it off. They were going to go. They were going on trips. Well, what happens is that when you go right away, you get early diagnosis. That's the most important thing. And it can be as little as a drop. In my case, it was a drop of blood. That's all I saw. The first time I ignored it, I'm like, a drop, okay. The second day, I'm giving you guys days. I'm giving you a countdown. Wednesday, drop. Thursday, I saw a little bit more. Friday, I'm in a doctor's office. So I want you guys to know that this is when you have to be your own advocate. See, oftentimes, bleeding with women is normalized, even after postmenopausal. And that's your one thing that I want to take away for our young women in the room. When you have an abnormal bleeding, when you're going through pads and you almost have to put on a DPN, go to the doctor. That's the most important time that you need to go. Because when I went to the doctor, the first thing, of course, I'm going to give you a little detail, that Dr. Hopkins is going to give you more. But what happened to me is when I first went, I saw a general practitioner. She said, well, the only thing I can do now is send you to a gynecologist. Second thing, women over 65, we still need to see the gynecologist. You know, I haven't been seeing one. That's another stigma. Like, okay, Jolene, you postmenopausal now. You don't need to see a gynecologist. Well, guess what? I did, because that's where I went next. And I want you guys to look at these quick successions of what I did. I went right away. I didn't say it's going to go away. No, I went right away. Second thing is I got into treatment right away. Second thing, I finally got to see the gynecologist who gave me a biopsy. One thing about a biopsy, he said, you know what, we're going to do a biopsy. They take out all these different tools. Let me tell you something. A biopsy, the one that I had, it was very painful, but it was necessary because that's the only way you're going to find out whether those cells are normal or abnormal or if you have endometrial. Let me also say all abnormal blood bleeding does not mean cancer. I know a lot of times people think, oh, that means I have cancer. No, but it does need to be looked into. It should not ever be ignored. So after I found out from my biopsy, okay, now, Geraldine, you have cancer. But one thing that I had was a team. I got sent right away to oncology. And I'll never forget my oncologist turning around in his chair, looking me in the eyes and saying, Geraldine, you saved your life. Second takeaway, you're your advocate. You're your best advocate. You know your body better than anybody else. That gut that we have is developed for a reason. When you have a gut feeling that something, anything is not right, that's why we have medical insurance. And if we don't, now we have all other type of social services support. Please don't delay because of money. There are so many organizations now, Black Health Matters, Ecana, where I'll also make sure you get more information. There's so much more information about how we can get treated. And that's the one thing that I want you to know. And I also want you to not be afraid. I know it's hard when we hear that word cancer, but then there's more people like me. We're surviving it. And we're coming back saying, yes, we were fearful. Yes, but I'm so glad that this organization look at mind, body, spirit, because you already got a head start, that those three all go together because we must have that faith. I will not be here talking to you if I didn't believe that God had saved me for such a purpose as this, to talk to you, to educate you so you can see me. I survived it. And I know I need to update my my biography because guess what? No sign of cancer. Yet 2023, I celebrated. I don't have it anymore. Thank you, Jesus. I am so thankful. I'm thankful that I survived it. So I can come and tell you that, yes, I went through the chemotherapy. Yes, I had the whole entire hysterectomy. At my age, well, who cares? That was like, okay, take this. But I know with younger women, that is a concern. But there's also, Dr. Hoskins going to talk about all different avenues. But what I want you not to be afraid of, and I always share this, don't be afraid of losing your hair. It's going to grow back. I have alopecia. Mine ain't growing back. But so I didn't have to worry about that. But what I want you to understand is don't delay. It's very, very important. We as African-American women are high risk for this cancer. And research is so important. If you have an opportunity to get into a research study, please do. We need more people that look like us in the study. I've been in all kinds of studies. And when you get in a study, contrary to what we know with our history, you get the really best treatment when you're in a study. Because you're going to see all the doctors, you're going to see the nutritionists, dietitians, everybody. Do not be afraid. And most of the time, you're going to get paid. So don't let research scare you. I'm a research person. Been in every time they say research, my hand is going up. The more I know, the more I can share. And before I end, I just want to tell you a little bit about risk factors. One of the risk factors, and we know this is high in our community, is diabetes. I'm dealing with it right now. So if you've been told you're pre-diabetic or don't overlook it, get it treated. I didn't know these risk factors. No one ever told me. Another risk factor is if you take tamoxifen. I was a tamoxifen research. I was one of the people that was in the research way before it ever got approved for breast cancer. These things we don't know. Taking estrogen, pills, patch ring, these are risk factors. These are things to be aware of. It doesn't mean that if you're doing these things, you're going to get endometrial cancer, but it's so important to know your risk factors. Another thing is family history. So for me, I have a daughter. I have to let her know this you're at risk. So now that you guys know about endometrial cancer, you now know that it is, if I didn't say it, it is the lining of the uterus. A lot of people think it's endometriosis. Two different animals. No, yes. Those don't marry. So endometrial, it's a uterine cancer. It is one of the highest, and we should always talk about this at any gathering that we get to. And I'm so proud to be able to share with you guys today the importance of talking to our sisters and our brothers, because we know we need to have our partners be aware that we are at risk. And another thing I know, Dr. Hoskins is going to talk about it, is my obesity problem that I'm working on. All of these things put us at risk, but guess what? These are things that can be managed if we know. So the more we know about this cancer, the more we know about the treatment options, the more we know about our risk factors, the better our survival rate. We want to get this survival rate where we will be here, that we will keep our legacy of love and all the beautiful things that we bring to the table. We want to keep this going. So thank you so much. I'm just thankful to be here.
And you have about, what, almost 50 young ladies in the room that are cheering you on. Thanks so much, Jerlene, and for the wonderful testimony. And now we'll hear from Dr. Hoskins.
Thank you.
Mhm.
Hi, all. Good morning. Just going to get my slides in presentation mode. So excellent talk. You got so many great points. And I think what we'll do is I'll expand upon some. I know we have not a very long time, so hopefully we'll have enough room and time to go over some questions and answer. So we're going with the theme gynecologic health, what Black women should know. So listen, this is a short period. We cannot get it all, but there's some key points that I wanted to go over today. And so this is our objective. You're probably like, who is a gynecologic oncologist? I'm going to explain that. We're going to go over anatomy because folks don't know the anatomy. It's just down there and we need to know the anatomy. I'm going to really very briefly go over the 5 gynecologic cancers that I take care of. And then the main portion of the talk is about endometrial cancer. And that's in my practice in DC, that's what I see the bulk of the time. I would say 60 to 70% is endometrial cancer. And I don't know why, in terms of that percentage, when you go other places, it's different, but certainly in my region, it's there. So who is a gynecologic oncologist? We are board certified OBGYNs. So we complete a residency in medical school. I'm sorry, we complete medical school, then we do a residency, 4 years of OBGYN, and then we do an additional 3 years of training in gynecologic cancer. We learn about the biology of cancer. The bulk of our time there, I'd say the 2 out of 3 years is just surgery, all day long, surgery. We learn about cancer therapy, anti-cancer therapy, like chemotherapy. And now we have new classes of drugs. And then we do a lot of research and learning about research, trying to advance the field. So that's who I am. I'm a gynecologic oncologist, or you may say GYN oncologist. That's what I do. And that's what who takes care of women that have these gynecologic cancers. Female anatomy. So these are the pictures I found. So the vulva is the best way to describe it. Here we have the labia majora. That's the large lips, if you will, labia. Labia minora is the smaller ones, the vaginal opening, anus, clitoris, the urethra. The urethra is between the vagina and the clitoris. I'm putting it out there. That's what it is, y'all. So let's go to the internal anatomy. Internal anatomy, we have a cervix, or some people call it the womb, the opening to the womb. And so when we do our pap smears, if you can see here, when we do our pap smears and put a speculum in, we only see the entrance to the cervix. There's actually an additional, I would say 2 to 3 centimeters of cervix that's there that we cannot see, called the endocervix. This is the lining, or the endometrium. And then this is the uterine corpus, or just the uterine body. So sometimes you may hear us interchangeably say uterine cancer. That would encompass, say, a sarcoma of the uterus and endometrial cancer. Our talk is going to be focused again on the endometrium, but they include them all. Then we have the ovaries and the fallopian tubes. Okay. I know I can't get any feedback, but I think y'all are saying okay. All right. Sorry. Let's see. So briefly, I thought it's a couple of reasons why I brought this up. Vulva cancer. So you can have a cancer of the vulva. And it's not a huge number, but people need to know what symptoms are. So about 6,500 women will be diagnosed in 2023. Symptoms include itching that doesn't go away, skin changes, whether it is darker in color, lighter in color, or bumps, pain or bleeding, open sore. You may have heard people say, hey, I've had condyloma or genital warts. Those don't typically go to cancer, but sometimes growth like that can look like a cancer. So they need to be biopsied. So these are symptoms, if you will. We already talked about what's a symptom. The symptom is what you experience, basically. And sometimes it's not even a cancer if someone has itching, but it still needs to be evaluated. Okay. And I'm going to give you a story shortly. So the next one, did y'all know that there is a such thing as a vaginal cancer? I can't hear you, but anyway, probably not. I'm gonna put it on there. Let me see if I can move my slide. Here we go. So that's actually very rare. It's 1 to 2% of all cancers that can be associated with human papillomavirus. That's the virus that causes cervical cancer. They may not cause symptoms. Okay, with a vaginal cancer, unusual bleeding, pain, urination, bowel movements. These are some symptoms. I give this story. I think, Jerlene, thank you so much for bringing up this over 65 part, because there is data that's out there from the internal medicine folks that say, hey, if you've had normal exams, And normal pap smears after 65, you can stop having, like, I think it says you can stop having pelvic exams unless you have a problem. Well, these are women. I think largely the OBGYNs do not agree with that recommendation because someone's got to look down there. I have had, last year, I had 2 women after the age of 65 that came in with bleeding. They couldn't really see what was going on. They came to the doctor. And then one of them in particular, I said, and she said, well, I haven't had a pelvic exam in over 5 years. I think she was like early 70s. And I'm like, why not? She said, my doctor told me I didn't need it anymore. And she had a stage 2 vaginal cancer that needed radiation and chemotherapy. Now, we just said that this is rare, but I think our take home point that I want you to say, like, again, I don't want to make it seem like, oh my God, everything that's going on down there is cancer. It's not. But my take home point is, if you have symptoms, see a doctor. And second, you still need a pelvic exam, symptoms or not. I think people need to look because there are other problems women can have as you age that are not necessarily cancer, but that may need to be addressed to prevent it. Okay, so that's that one. Cervical. Again, now we're getting to stuff that we probably know. Approximately 14,000 women will be diagnosed this year and about 4,300 deaths are anticipated. About 95% is caused by human papillomavirus. You may recall that this is the virus that causes cervical cancer. This is the same virus that we are addressing with adolescents with the Gardasil vaccination. And that vaccination could prevent cervical cancer. Can you imagine that we have a vaccine that could prevent a cancer, but the uptake of that and giving it to adolescents is very low? And even adolescents, you can actually get the vaccine up to age 45. So, we have things to prevent. So anyway, so we have the pap test and HPV screening tools. Women who are diagnosed typically are diagnosed between the age 35 and 44. Most women, but 20%, here goes that age 65, 20% of all these women that are going to be diagnosed, what age are they? Greater than 65. So again, the primary, I find that some of the internal medicine doctors don't feel comfortable doing a pelvic exam. That's fine. I would still make sure you see a GYN. And sometimes it's not, Medicare doesn't pay for it every year, but they will pay for every other year. And I think you take advantage of that. And then the other thing I wanted to chime in on cervical cancers, most women do not have symptoms because we have pap smears to detect cervical dysplasia, which is the precursor or the lesion that you develop before you get cervical cancer. So most women that don't have symptoms, the ones that do have symptoms typically are ones that have not seen a doctor, has not had a pap smear, and have advanced disease. So this disease, we already said, is preventable. Okay. Ovarian cancer, huge topic. We're not going to go there, but just go over some statistics and symptoms. 19,000 women will be diagnosed this year. Look at how many deaths. It's not necessarily all those women will die, but a lot of women who do get diagnosed will die of the disease because we don't have a screening test. The diagnosis typically is late stage. There are some women that are genetically caused. So 1 in 78 women are at risk. So that's a population risk, which is a lot different than, say, a breast cancer where it's like 1 in 8. So it's not prevalent, but when the ones who get it, it's deadly. That's the take home. Symptoms for that: common symptoms, bloating, pelvic or abdominal pain, early, like feeling full when they eat. And these are very vague symptoms. I felt bloated last night eating some bad food, right? But that's not when you're going to call your doctors. Things that are vague, that are persistent. So I always tell folks, and there's a recommendation, it's been going on for 2 weeks, probably get in to see your doctor. Don't let it go for 6 months because that's a big difference. And anything that's a change from normal. Again, 1 day is probably not a big, but it's, hey, I've noticed this in a week, going on 2 weeks, try to get in to see a provider. And then if you guys have questions, we'll address them at the end if you can write it. So going on, now I'll piggyback off of what Mr. Arlene said. Endometrial cancer, I put this picture, where's the endometrium again? That's not what we learned. We know where the uterus is, right? And so the endometrium is what a woman sheds every month when they have a menstrual cycle, right? This is the same lining that builds up to accept a pregnancy every month. Except when it's a postmenopausal woman, you should no longer be building up and shedding, right? So you shouldn't have any bleeding. So any bleeding does require, or really should be assessed. And sometimes the bleeding is benign. Some is like a growth of the lining that is outpouching here. That's called a polyp. That's benign. Sometimes it could be, something called endometrial hyperplasia, which is not necessarily benign, but it's a precursor for endometrial cancer. So anyway, it's a cancer of the lining of the endometrium. This is I got from the American Cancer Society. Please note that this statistics includes the total uterine cancer, including endometrial and sarcoma. About 10% are from from sarcoma. So we can just say around 60,000 women will be diagnosed this year. Now, no lie. I think I've been out of my training. This year be 12 years. And when I first got introduced to the subspecialty, okay, so let's just say 12 years, the statistic has gone up. Remember how we're supposed to like decrease down? This is the one cancer that has gone up. So I remember when the estimated cases were 40,000. No diet. And I'm not like I'm 70 years old. Like it wasn't that long ago. So this cancer is on the rise. And the biggest risk factor that we see that's positively correlated is obesity. Why obesity? Again, we're not going to go through the science of it all, but the fatty tissues can produce estrogen. Estrogen stimulates the lining. Just like if somebody is having a menstrual cycle, estrogen stimulates the lining, then they shed it. So that same estrogen, a type of estrogen, the fatty tissue, can stimulate the lining of the uterus, which it shouldn't, right? Because you're menopausal, and that continued exposure, if you will, not balanced with other hormones, can be detrimental. So these are just going through body mass. The risk goes up with being overweight and obese. So I don't know if everybody knows their body. I'm going to tell you, I'm considered overweight. And so those are things that I'm working on daily, and everything I eat and do and exercise is a daily choice, because we know that diseases are affected when you get to higher like a higher body mass index. These are our other risk factors: heart disease, stroke, high blood pressure, hypertension, sleep apnea, gallstones. Sorry, I can't see this top part. Increased BMI associated with these things. And then it's other cancers that can be associated, even estrogen receptor positive breast cancer. So, I mean, it's like when we eat and when we in our lifestyle, we got to say, is it worth it? It's not really. Unopposed estrogen, early age of menstrual cycle, late menopause, estrogen. I'm going to tell you the biggest risk factor is weight. I think I see use of tamoxifen. So the women who are on tamoxifen has an estrogen-like action in the uterus. So, but it puts it slightly high risk. And then the biggest thing, like I said before, is obesity. Did I talk about it? Genetics. So, if you have a family history, someone is like, oh, colon cancer runs in our family. That's Lynch syndrome, possibly. Lynch syndrome is associated with endometrial cancer as well. So family history, I always say, if you got a huge family history, maybe genetics testing makes sense for people who are affected with the disease. This, what this is for, y'all? This is to show you. I got to move my screen because I can't see it. Hold on, bear with me. Mortality rates by race. Who's higher? Meaning mortality means death. Morbidity means disease, but mortality is death. We are 2 times higher risk of death compared to white women. So I used to think it's because Black people, we don't have access, generally we don't have access to healthcare, or we take too long, or we're in denial. And I think that's kind of what the white folks have said, oh, y'all poor, y'all don't know, or, whatever. But what I've seen as a provider, and, we all have our own biases. What have I seen as a physician is that I see women who had the same one drop, came right in, and the disease is bad disease. So I think biologically, and there needs to be work on it, clearly, it's just different disease, different. I worked in the suburbs of a town outside of DC. The patient population, white women with endometrial cancer, I hardly ever recommended chemo, because they just had the disease that didn't need it. But I promise, I feel like anytime I see a Black woman, which I see most of my patients are Black women, I don't even speak too soon, because there may be a chance that you need chemotherapy and radiation, even when it looks like it's not that bad. It's just, I don't know how to describe it. So I just think that more work needs to be done. I think we're trying to do more in terms of trials, et cetera, about this disparity. So knowledge, you talked about this, but I think we got to talk about it. Let me just see. Okay, knowledge gap. Okay, unclear about what is normal and abnormal. Okay, I just saw somebody yesterday and she said, well, my period came back. No, that's not your period. It's not a period. It's abnormal postmenopausal bleeding, or it's abnormal bleeding. It is not a period. When you say things like my period came back, it normalizes it, and it's not normal. So unclear about normal or abnormal menopause. I also say, when I see people that say are 55 and they haven't gone through menopause and still bleeding, that's also one of those things that make me think she needs to have a biopsy, because there may be something else going on. Misinterpretation of bleeding symptoms. This is actually, I think Kimmy Dahl actually did this one about what the gap is. Non-disclosure of symptoms, meaning they didn't want to. I have an aunt that passed away of an advanced carcinosarcoma of the uterus, because apparently she had been bleeding and never told anybody for who knows how long. By the time she got into the hospital, I think she died within 2 weeks of being hospitalized. It was too late. So not disclosing symptoms. Vague responses from healthcare providers. Listen, you're going to be your best advocate, period. Oh, well, my doctor, I asked him to do ultrasound. He didn't get a different doctor. That's it. If you can't get it from that doctor, insist on doing it. I mean, I just think you just have to, you know, we have to be heard. And a lot of times I feel like we as Black women are not heard, period. Even when you're a doctor, you're still not heard. So you have to be assertive for your care. And then the shock and the surprise for the diagnosis. So some people, they hear that and they just don't want to deal with it. But then when you're not dealing with it, things grow. Okay. What is menopause? It seems real basic, but I feel like we have to talk about it. No cycle, no period for 12 months. You have a decrease in estrogen and progesterone production, typically between 45 and 55. And then some women have removal of both ovaries, and that's considered surgical menopause. Symptoms of endometrial cancer. Majority of patients have postmenopausal bleeding. Now, let me go ahead and put this out here. Oh, I said it there. So postmenopausal meaning like someone's gone a whole year with no bleeding, and then boom, a spot. That's postmenopausal bleeding. A spot is bleeding. A pink discharge is bleeding. Heavy bleeding is bleeding. So basically all of that is abnormal. Now, what I do see with the obesity epidemic is we start to see younger women. So it used to be like, if you're supposed to do a biopsy, but now I see, I actually did a surgery on a 34-year-old with endometrial cancer. And she had the risk factors, right? She was morbidly obese, didn't have regular periods. And so those are people, if it's abnormal uterine bleeding and she has not reached menopause, she needs biopsy because we see that that's there. And then incidental findings on ultrasound. So like, oh, I felt the pain, and then they see something. Sometimes you can pick it up that way. Clinical evaluation. What would they do? Follow up, get a history from you, do an exam. They may do a pap smear. Remember, pap smear detect cervical dysplasia, does not detect endometrial cancer. And then typically need a biopsy, right? So the biopsy can be in the office it's a small little instrument that goes through the cervix, through the uterus, and it suctions. And then sometimes your provider may say, you know what, I want to take you to the operating room and do a DNC hysteroscopy. That's basically very similar to endometrial biopsy, but you'll be under anesthesia. They can put a camera inside, take a look around, then biopsy. Kind of depends on the scenario. Surgery is our primary mode of treatment, meaning we take out the hysterectomy, is the removal of the uterus and typically cervix, removal of the ovaries and fallopian tubes, which is a bilateral salpingo-oophorectomy, removal of lymph nodes, a lymphadenectomy, and then washings, meaning we put like fluid in there and then collect them. Surgical approach, I mean, typically we do it robotics, probably not as important, just showing you what it looks like. That's me, that's the robot, not doc to a patient, but this is what it looks like. And I control it from this instrument. And then again, I always tell patients, like even the ones I'm like, okay, this looks like it's great. And then sometimes I'm like, oh, this is gonna be good. And then it's not, there's a need for treatment based off of the final pathology. So we need all the pathology, and that's how we stage. We don't necessarily get a PET scan or a CAT scan. We need the tissue from the surgery. We look at it all, and then we stage and then determine the next steps in terms of treatment. That could mean doing no treatment or observation. It could mean radiation alone. It can mean chemotherapy alone. It can mean radiation and chemotherapy. It could be, you know, all these other options that's there. And then I think we talked about this, the mortality, 5-year mortality rate is 39% in Black women, while in white women is 20%. And Black women are more likely to be diagnosed with late stage disease and more aggressive tumors. So what's next? I would love to chat about GYN cancers or endometrial cancers, things that we can do to help ourselves, healthy BMI, open dialogue with friends. Open dialogue with friends, family about, oh, I had a spot. Oh, that's not, normalizing our, talking about that, advocating for your health, read on the diagnosis. It's okay to question your medical provider. Plenty of people do. This is no longer the society where it's patriotic and the doctor said, and we just go along with it. If it doesn't feel right, ask questions. And then we, like you just said, Mr. Lee, enroll in clinical trials so we can learn more and do better. That's it for me.
Yes, thank you so much.
Let me stop sharing, sorry.
Thanks so much, Dr. Hoskins, and thanks so much, Darlene. We're now ready to take questions. And I see we have one right now in the chat. And then I also have a number of people here in the room that have questions as well. So I'll start with the chat. Let's see. Okay, this is a person that's asking a question. I used to be a pharmaceutical sales rep back in the early 2000s and called on gynecologic oncologists in South Carolina and North Carolina. Every single GYN oncologist in my territory was a white male, so I'm very excited to see and be on this call with Dr. Hoskins this morning. Are you aware of an increase in African Americans, especially female African Americans, pursuing this specialized field of oncology? Great question.
Oh yeah, I think the field is definitely changing. From the time I entered, was a student, I would go to these society meetings and it was only white men. And then now we have you know, the specialty, I always just say women, a lot of the society now are women, and there are some Black women. We're still not going to be, you know, more than 10%, but they're definitely, and my partner, she is a Black woman and very, I mean, we're here. You may not find us in every town, but we are here. You're going to see more.
Great, great. Okay, I'm going to take one from the audience here. Would you like to share your question?
Yes. My question is, taking estrogen or using patch postmenopausal, still in are you still at risk or to be at risk for uterine cancer?
Did you hear that, Dr. Hoskins? I can repeat it.
If you could repeat, I think she said if you take
Okay.
estrogen, but I wanted to clarify.
Yes. So if you're taking estrogen or using the patch postmenopausal and you still have ovaries, are you still at risk for uterine cancer?
The biggest thing is that you'll see unopposed estrogen. So you can take estrogen, but if you still have a uterus in place, it should be with progesterone.
Okay.
So
Thank
like,
you for that.
yeah, so if you
Okay.
have a uterus in place, it can be estrogen and progesterone.
Okay, and then I'll take one online. What should be included in the GYN exams for women over 65, including those who have had a hysterectomy? And I believe you touched on this as well, Dr. Hoskins.
So again, a hysterectomy, we say that word all the time, but does that mean removal of the ovaries? Because the person may still have ovaries and fallopian tubes in place. Does that include removal of the uterus? Does it include the removal of, because some people have taken out the uterus and still have a cervix. So I would say it still should include at least a pelvic exam. Pelvic exam means that they've looked on the outside of the vulva, which isn't taken out. And sometimes we'll take a look and to see if there's a cervix left, and the palpation where we like palpate in the vagina. So that's a pelvic exam.
Thank you. I'm going to answer this next question that we have online. What strategies to implement, and anyone else that'd like to answer, we could do that as well. What strategies to implement to recruit more African-American and women in clinical trials? Well, we host programs, Black Health Matters, like this across the country. We have summits. We also go out in the community. We work with the church community, the faith-based community. It's about being out there. Jerlene's out there, Dr. Hoskins in the community, and really getting out there and getting the word out about clinical trials and the importance of it. And we will continue to do that. We have articles, we have social media. I think it's gotten a lot better since COVID. Now people know what a clinical trial is, but we still have a lot of work to go. So definitely. Someone in the room?
Oh, I want to just
ahead.
sideline. I think there was a mandate from, I forgot the number, but mandate from the FDA that
FDA, yes.
have to include more women of color, really particularly Black women. So now all of a sudden, these same companies that I was begging to come to the hospital are now like, hey, we need to get in your institution because they're mandated to have more patients. So that's true. I think a positive. Yeah.
Yeah, and that's something we reported on as well.
And I just like to add, also, we need to get over this myth of what happened with Tuskegee. I'm still dealing with that when I go out and I'm recruiting. What happened in the past, that's the past. You know, we want to live. So the only way we're going to be able to know why it's impacting us, as Dr. Hoskins said, it is something going on, whereas a Black woman can go in with a spot of blood and be at stage 2, and a white woman can go in with a spot of blood and not need any, maybe minimal surgery. So if we don't get in it, and I've been out there beating the bushes, I want to let you know, whoever it is out there, I've been beating the bushes, I've been getting a lot of resistance, but I'm not going to stop beating the bushes. We got to get in these clinical trials. If nothing else comes out of this, please, we must join the clinical trial.
Definitely. There was someone that raised their hand here. I'm just trying to, one of the attendees. I will allow you to talk. Linda. I don't know if we can hear her talking permitted.
She's muted, I think.
Okay. I will go to the next question while Glenda is unmuted. Let's see, hold on. Can I unmute her? No, I can't. Ask to unmute. Okay. I know ACOG changed the guidelines for annual Pap smears. I am 41 and do not feel comfortable doing my Pap every 2 to 3 years. Why did ACOG change guidelines, and how can I advocate for myself to have a Pap annually?
Okay, great question. I think, so what we've known from 20 years ago from today is that HPV causes cervical cancer. So the thought is, if you don't have HPV, say today, the likelihood of developing a cancer in say 3 to 5 years is very slim. You don't have the risk. Now, you could acquire HPV, say the following year, if there's a new partner that's present. But what we find is those cancers still don't develop until 6 to 10 years after exposure of HPV. So that's where that goes from. You can still go for a pelvic exam. You may not necessarily need a pap smear. A pelvic exam will still have someone take a look, feel, but it may not necessarily include the pap smear.
Okay, thank you for that. Here's another question. Is there a timeline for growth from precancer to cancer?
For endometrial or like, for example, cervix, I think I just said it, like from HPV to dysplasia to cancer, the average is anywhere from 6 to 10 years. Excuse me.
Okay.
For endometrial hyperplasia, I don't have a great answer for that. Endometrial hyperplasia is another precursor lesion for endometrial cancer. I can say that I had a patient that had endometrial hyperplasia with atypia. We treated her with IUD, completely resolved. She didn't like the IUD, took it out. I think we took it out in the fall of 21. Then her GYN called me back literally a month ago and was like, oh, now she has endometrial cancer. And I was just like, anyway, so, and it was like a year or two.
Wow. Dr. Hoskin, I think you're a little bit frozen.
Oh,
Okay, now you're back.
okay.
Okay, good. We have a couple of questions about hysterectomy that involve hysterectomy. So I'll read this one from someone in the room. Should you possibly look at having a hysterectomy if you have had issues with bleeding for 7 weeks due to thick lining and after have some of the lining trimmed? Is weight the main cause of thick lining?
Well, so there's a couple things. When the doctor needs to biopsy the thickened lining. So the thickened lining could be, like I told you before, endometrial polyp. It can be endometrial hyperplasia. It can be endometrial cancer. It all depends on that pathology. So if the pathology is a benign endometrial polyp, and I can manage that without going through a major surgery, I'm going to offer you a DNC hysteroscopy. If it's something that I think is a hyperplasia that's lower risk for cancer, I may manage that with hormones. If it's hyperplasia with atypia or endometrial cancer, then I get the take home point is that doesn't necessarily require a hysterectomy. It depends on the pathology. So make sure that when you, or you or whoever has that biopsy, that they look at the pathology and it's truly benign. Because sometimes they say, well, my doctor says, okay, well, do you know what the result was? No, I don't know what the result. Remember, we need to know what our stuff is, right? For ourselves.
Yes, definitely. So here's a question online. If you've had a hysterectomy but still have ovaries, are you still at risk for endometrial cancer?
No, you're not at risk for endometrial cancer because the endometrium is removed, but the ovaries are still present. So that's why we still say pelvic exams, because the ovaries that we briefly talked about is still a risk.
Mm-hmm. So I'm looking here. We have time for maybe 2 more questions. Anyone else in the room? Yes, come on.
The robot lab has been innovated with information that says that African American women who had perm hair and have developed ovarian cancer, fibroid tumors, endometriosis, that there's supposed to be some class action too. Do you know anything in regards to that? And is there any truth to that? Because when you go on Facebook, it pops up.
Yes, we've all seen it.
I think
Dr. Hoskin.
I feel like I can't speak on it that well because I feel like I don't know. I think it came out of the Journal of National Cancer Institute that saw a correlation of, I think it was perms with uterine cancer. From a physician standpoint, I'm like, I guess that's possible, but I would want to know the science. How can you prove it? I don't know that. I really feel like that's just based off of one paper. I want to see more data. But remember, people are out here. I'm not saying that it can't
make money, right?
Right. So especially there are certain law firms that are just down for class action suits as soon as that paper came out. And I believe it's just based off of one paper. So it could be true. I just personally would want to see a little bit more cause and, causation like that.
Yes. So I know we have a lot of questions.
Would we be willing to take those questions and have them answered? We can go at least 5 to 10 minutes.
Okay. Well, okay. Okay, thank you. So we're going to take a few more minutes because we have a lot of questions in here, and then we also have questions in the room. So let's try to answer some more of these questions. This is such a good conversation that we never really get to have, right? Mm-hmm. So let me see.
I think I only have like less than 5
Oh,
minutes.
I know you.
Okay.
That's right. You're in clinic today. And
yeah.
Also in the hospital. I'm sorry.
That's okay.
What we can do is we'll take the questions that we don't get to answer and we'll send it out to everyone anonymously, obviously. We'll answer them and then send it out with a thank you note. And also remember to complete your surveys that you have. It should be online for those that are online. And we have the surveys here in the room along with the Spot Her fanny pack. Don't you wish you were here? One question here, what age should we take our daughter for an exam? You'll type in an answer to some of them.
So they typically start pap smears at age 21. They say as sexual debut. I don't know that number exactly, but Like if someone is sexually active, yes, they should go for an exam. If they're not, then the thought is 21 for their first pap smear at least.
Okay, here's another question here. My pathology report showed negative carcinoma margins post hysterectomy. Is radiation necessary? I had a 5th round of chemotherapy yesterday and have another in March.
That's I can't answer that because I don't, it's
That's
not
up to your
incomplete, it's
doctor.
incomplete, it's an incomplete data. Like I don't have the pathology to know.
Yes.
So, and the
Yeah, you
statement,
would
so.
need to your own HCP for that. One, here's another question. Why are fibroids more prevalent in Black women? Is there a connection between fibroids and uterine and or cervical cancers?
I'm not sure why they're more prevalent in Black women, but there is no connection between fibroids and uterine cervical cancer.
Okay. Here's another question. Maybe some of them we can also answer online. Is there a standard of care protocol for which patients require just radiation or both chemo and radiation? Patients often receive mixed opinions from GYN oncoms about exactly what treatment are best for a specific patient.
Yeah, there are standard protocols. They're called the National Comprehensive Cancer Network protocols. Or NCCN guidelines. So NCCN is kind of a standard guideline that says if a patient has stage 3, blah, 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 this way. But then I will always ask, so I think it's good. It's definitely written for a medical provider. So there are standards out there, but I always will tell you that sometimes there are guidelines. We as physicians, if one, got to make sure you're with a physician you trust. Number 2, sometimes we base our decision based off of the patient and whether we're able to tolerate, whether they can tolerate it and a lot of other scenarios. So it's not just an algorithm. Okay.
Yes, and just, I know you need to run, don't you?
Okay.
So
yes.
we will take the questions here, but just know that we will have this session online on Black Health Matters YouTube channel, and we'll be able to, we'll be taking this recording and putting it online for those that would like to see it again. Also, we will take these questions, capture all of these questions. How do you get involved with Black Health Matters? Contact us. You can contact me at Leslie at Black Health Matters or info@blackhealthmatters.com. And also, please remember to check out Sister Love at www.sister-love.com. Again, that's www.sister-love.com. And also, please check out information about Spot Her, hear the stories of Jarlene and many others at spotherforec.com. And there's also ecana.com.
Yeah.
And the last question, she's not on any longer.
So
we will have to take these questions and we will give everyone the answers in an email. Please complete the surveys that you have and online, as well as those that are here in the room. Thank you all very much for your time. We really appreciate it. Thank you. And I wish you all good health and a wonderful weekend. Thank you.